Good evening, everyone. Greetings from Translumina. A warm welcome to all the delegates who have logged in, as well as the formidable set of faculty who are part of this inaugural session of West Interventional Cases 2021. First of all, I would like to talk about the inaugural topic, which is techniques and treatment of severely calcified lesions with intravascular lithotripsy. So this session will be moderated by Dr. Selvamani, who need not need any introduction, but nevertheless, sir has close to 2 decades of experience, and sir is a senior interventional cardiologist based out of Meenakshi Mission Hospital and Research Center. So sir is proficient in all the newest modalities that are existing in the market. So over to you, Dr. Selvamani for the session, sir.
Yeah, good evening. Thank you very much for calling me here, and then nice being with all seniors and colleagues and friends here. We have great chair with Dr. Lucas, Dr. Kirti, and Dr. C.N. Manjunath, the legends in cardiology here. And of course, we have a very good panelist, my good friend, Dr. Hazra, Chadha, Samir Dani, and then we have Vijay, YVC sir there, and again, Rajesh and Shrivastav and PC Rath in the panel. And I think this topic is always there because calcified lesion, it's always not easy treating it. And every day we are learning new techniques and evolving new modalities to treat this. But still we are yet to conquer calcified coronaries completely. And we hope that we'll have a very good learning from this session today. And I think we will go to the topic. I think the first speaker will be Dr. Lucas here. He is going to talk on calcium management in IVL, a right choice of treatment. Is it a right choice of treatment? And it's over to you, Dr. Lucas, please.
So thank you very much for this kind introduction. And of course, I totally agree with you when you said that, well, it's obvious that the calcification is still some of the nightmares for the interventional cardiologist. I've been preparing this presentation. I hope that, okay. So first of all, I'll just say I work in Milan since 12 years. I did my training in Rome and then in the UK at Oxford University. And I'm starting using this technology almost 3 years ago. But before starting talk about the intravascular lithotripsy, let's talk about the calcium, because the calcium is not so rare. And if you only look at these factory slides, you will see that in time, the percentage of patients coming to our lab with a classification according to the ACC classification type C lesions is increasing, steeply increasing. But also in terms of the prevalence of the calcification, this is obviously related to the aging of the population, but this is something that has, important implication for the outcomes, and that's the point. If you look at this pooled analysis from the Horizons Army and the Acuity, you will see that in almost 7,000 patients, the rate of MACE is strongly correlated with the presence of severe calcification as compared to the presence of moderate or even mild to none calcification. So that's why we are talking about calcium. But what's the point? The point is that the calcified coronary lesions are still in 2021 an unmet clinical need because the presence of the calcium increases the safety risk, impedes the stent deliverability, but also may prevent the stent expansion. And this is one of the major limitations that we have. In particular, when the calcium is very superficial, very close to the lumen, it may really impede the stent deliverability, thus reducing the procedural success, so the possibility to deliver the DES. Sometimes, of course, because of the presence of calcium, you may have this underexpansion, and we all know that the underexpansion is associated with an increase in ischemic events at 1 year, in particular stent thrombosis and stent restenosis. Of course, the presence of calcium may inhibit the circumferential expansion, and in some extent, of course, we all know, we are used to see that stents are not perfectly circular. This is not a problem. However, when the stent is truly eccentric, this may be a problem because it poses an endeavor for stenosis and thrombosis as well. But of course, not all the calcifications are equals. We will see during this session about the imaging and the possibility to classify the calcium in several ways. However, this is something that we need to remember, in particular for our young colleagues. Not all calcifications are equals. This is just a table to summarize the options that an interventionalist has in his portfolio. And of course, we may distinguish between the ablation techniques and the balloon-based techniques. There are, let's say, lights and shadows everywhere. However, let's start from the older stuff. So there are some limitations concerning the balloon-based therapies because the high-pressure balloons preferentially expand away from the calcium, having limited effect on the eccentric calcium. Also, the high-pressure inflations are predisposed to major dissection and perforation, often at the interface between calcium and healthy tissue. So balloons are typically unable to modify the deep or very thick calcium. But what about the atherectomy therapies? Well, they require a dedicated wire. First of all, the thermal injury promotes the platelet activation, and the distal embolization it's quite, let's say, common. The ablation is contact dependent, is unable to modify the calcium in larger lumens and deep calcium. And for the operator who is, let's say, expert in using the Rath ablation or the orbital atherectomy, you know that in some extent, if the vessel is large enough, the Rath ablation, for example, is truly useless unless the vessel is suboccluded. But we'll see that later on. This is the new kid on the block, the lithotripsy. The lithotripsy has been applied since 30 years to treat the kidney stone, but it has actually extended and applied to the vascular bed, actually in a very simple way. So applying the localized lithotripsy at the lesion location by means of a balloon. So this is something that you all know. Of course, I will not spend time to describe the technology because it's very known, very common now. But what is really important here is to show what's the beauty.
The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic
will basically create fractures inside the calcification, either the superficial and the deep calcification, in order to increase the compliance of the artery. So these are potential advantages, but in a few seconds we will discuss what we know from the clinical experiences, because of course in theory this technology is very interesting, it's very intriguing. However, we need to see if it does work or not. So let's have a look at the clinical program. So of course we will look after the Disrupt CAD 3 because it's the largest and is basically the IDE trial performed in the US. IDE means Interventional Device Exempt, and it's basically a trial that has been created to show the safety and effectiveness of the procedure. And as you can see, almost 400 patients. But the very first thing that I would like to point out is that at the moment, there are more than 85 peer-reviewed journal publications and more than 1,300 published patient outcomes. So this is really a big amount of data. And there is also a very nice consistency across the studies, in particular if you look at the procedure success as well as the stent delivery. Of course, I'm not talking about the clinical results because these trials were not meant to show clinical results, of course, small trials. However, the intent was to show that this technology is very easy to use, there is no learning curve, but also that is very effective. But let's spend a few seconds about this Disrupt CAD 3. So this is, as I said, the largest trial so far in 47 global sites, and the objective was designed to assess safety and effectiveness of the shockwave medical core intravascular lithotripsy system based on the Orbit Second. The Orbit Second is, well, an historical trial based on Rath ablation. Primary safety endpoint was 30-day MACE rate. Primary effectiveness endpoint, less than 50% residual and no in-hospital MACE. So enrolled 431 subjects across 47 sites. And there was also a sub-study with OCT. These are the baseline clinical characteristics. As you can see, typical characteristics of people, patients get into the cath lab. As you can see, there is a higher prevalence of class 2 and 3 angina. These are the angiographic and procedural results. So a lot of calcification. All patients were affected by severe coronary calcification, but the stent delivery on the right side of the slide is higher than 99%. And this is also the performance outcomes. As you can see, crossing success around 96%, procedural success very, very high as well. The diameter stenosis less than 30% was achieved in all patients, 100%. So let's have a look at the complications, of course, because you cannot believe that there is no rate of complication. There are some complications. However, we are talking about 2.6% in terms of any serious angiographic complication and 2.1% severe dissection type DF. But final is around 0.3. Let's have a look at the hospital MACE. Again, this trial was not meant to show an advantage in terms of clinical events. However, we need to remember that these patients are at highest risk for PCI because of the calcification as well. So, in terms of MACE, in hospital in 30 days, we see there is a big consistency, and at 30 days, it was 7.8%. But, well, of course, but it's just to mention that both the primary safety and effectiveness endpoints were met. There was basically no evidence of learning curve, and I found it very interesting. So we all know that one of the major limitations of the use of some techniques in our lab, and talking about the excimer laser, talking about the root ablation, the orbital atherectomy, is actually the presence of a steep learning curve. But for the shock wave, there's no learning curve at all, because as you know, it's basically delivering a balloon and clicking on a button. So that's it. So there is no learning curve. Let's say, well, also the OCT sub-study gave us a lot of information. And in particular, I would like to show you this. So there was, in particular, this very interesting point. So the device crossing was 100%. And the procedural success, as I said before, was very high. At the end of the procedure, we looked at the OCT in 100 patients, and then we obtained 0% of dissection, perforations, closure, slow flow, and no reflow. So the OCT study further confirmed how safe is the use of the shockwave. If you look at the OCT measurements, of course, I'm not going to go through all these details, but it's just to mention that at the end, with the post-stent analysis with the OCT, there was a strongly significant increase in the minimal lumen area and a decrease in max area stenosis. So all the numbers were strongly in favor of the use of shockwave. But also there is something missing. So with the OCT, we found that there are probably some calcium microfractures that the OCT cannot see. I'm saying that because there is no difference in terms of how many fractures can be visible with the OCT and the success of the procedure. So regardless the extent and the number of the fracture, the intravascular lithotripsy was successful anyway. So we may believe that the OCT sometimes cannot see all the fractures that we are creating in terms of longitudinal fractures, but also in radial fractures. And this is also what I meant before. So either you see a lot of fractures, either you don't see a lot of fracture, the shock wave increases the compliance of the artery. So these are the conclusions of this pivotal study. Disrupt CAD3, both primary safety and effectiveness were met. Coronary intravascular lithotripsy was well tolerated, low rate of major procedural, clinical, and angiographic complications. High procedural success, low angiographic complications, but also with the OCT demonstrated that there was a longitudinal circumferential gain in terms of calcium fractures in every calcified lesions. The minimal stent area, the area stenosis, and stent expansions were excellent, regardless of calcium fracture, as I said before. So let's have a look at the context. As I said before, the Disrupt CAD3 is a US pivotal trial, but in the context of the historical data, we need to have a look. And I would say there is a lot of consistency in terms of results, but if you look at the rate of severe dissections, perforation, abrupt closures. The numbers reported in this CAD3 are very, very well evident in terms of advantage as compared to other, let's say, calcium devices, calcium-oriented devices. The key learnings from this experience, of course, must be viewed in the context of an international application, because the DISRUPT CAD3, as I said, is a US pivotal trial, but the intravascular lithotripsy is now available in more than 45 countries. More than 25,000 patients have been treated since 2018, more than 60 peer-reviewed publications already, and a lot of people with the outcomes available. And has been, of course, the use of intravascular lithotripsy has been expanded to left main, bifurcation, tortoise nostril disease, but we will talk about that later on. We also will talk in a few minutes about the possible algorithm. This is an algorithm coming from the US, from the Sky, and this is an algorithm coming from Europe about the calcium content. Of course, I'm not going to talk about all this because we'll talk about that later on, but it's just a way to show that the lithotripsy has immediately joined the flow chart of calcium treatment. Just a brief case I want to show you. Of course, a case of patient with some abnormalities and ST elevation. We'll go very quick because, of course, the session will be based on a lot of cases. Of course, a lot of calcium, the proximal LED, as you can see in this other view. I'll show that. Okay, a lot of calcium, as you can see, circular calcium. We did the PCI to LCX marginal, but this is not the point. The point is that we did the OCT to the LED, showing a lot of calcium, a lot of circumferential calcium, and this is much more visible here. So you see in the proximal, you see in the mid and before that big diagonal, a lot of calcium. So we decided to use the shock wave, in particular in the first part, and this is the final result. Of course, the stent delivery was easy, and we did the procedure to the left main LED LCX. So I don't want to take more time for the live case discussion, so I'll go straight to the end. But of course, we need to answer the question at the beginning of this conversation, this speech. And the question, as I said before, this is the end of this case, is intravascular lithotripsy a right choice of treatment? Yes, of course it is. Thank you for your attention.
A very nice, extensive review of IVL and then good case demonstration, Lucas. And I think we are running behind the schedule. So we'll go to the next speaker, and probably we'll have the discussion in between or in the panel discussion. And is it okay with you, Lucas? You will be here with us, isn't it? The session. Sure. Nice of you. Then we'll go ahead. Next is Dr. Kirti Punamiya. And we have a very interesting topic. We have heard of rotatripsy, and now probably we are having a new term, laser tripsy. Like, we'll learn what he teaches us about this. It's over to you, Kirti, sir.
Oh, thank you, Selva. That's great. Yeah. Can everybody see the slides? Are the slides visible?
Yes, yes.
Okay, great. So I'll just go right into the cases. Now we have this, I think I'm going to use this platform just to, by virtue of showing the cases, the way we apply and then arrive finally at an algorithm that I follow in my lab for these complex PCIs. So here we want to start with a patient who is 75 years old and comes with a lot of comorbidities, with a CTO just at the proximal LED, which is calcified, which is JCTO score 3, and not great collateral, not any great collateral seen, though very invisible collaterals filling the retrograde part of the LED, as you can see in these two amalgamated pictures. And what we ended up doing was, with a little bit of a struggle because of that little short stump and the acute bend from the left main position, we were able to get a microcatheter. And once we got a microcatheter in there with a soft wire, we got this UB3 wire, which we negotiated across the lesion. Having done that, once the UB3 was there, we decided to advance our microcatheter, which is a fine cross. And you can see that microcatheter there, and it would not budge whatever we did. We tried to turn it around, twist it, we tried to shove it in, we deeply impacted the guiding catheter, but it would not budge. Now, in this scenario, we had our laser 0.9 fiber, as you can see. Initially, I'm showing you this because with the low fluencies at a 45 and even 60, when 60 reps, the catheter seemed to not budge at all. It's only when we got on to 80 reps that you can see that the catheter rapidly advances into the lesion and crosses that rigid part of the lesion. Though I must tell you that laser does not cross or break calcium somehow, but it does unbond the very densely fibrotic tissues that hold calcium together, thereby creating a path in between. And soon we had this kind of a lesion, which then becomes a regulation angioplasty. Once that is there, we next put in a IVUS catheter, and this is IVUS pullback from the LAD using 60 megahertz HD IVUS. And for us, that far left is the left main. We have the ostium of the LAD, and you can see there's a lot of calcium in this longitudinal view that you see in the proximal segment. When we do see some branches coming out, and then there's calcium restricted to one side in this longitudinal view. But it appears that from a landing zone to the landing zone in the left main, it looks like a 40 millimeter lesion in the proximal LAD. And then there is a relatively long area, almost like 5 reference vessel diameter length area, which was with the plaque burden of less than 40%. So we consider that as a normal part of the artery. And then there was a distal very critical lesion, which is again 18 millimeters in long and around 2.5 millimeters as the reference vessel. As you can see there, 2.25 to 2.5 are the landing zone measurements. And these were the proximal LAD measurements. So we knew that we had to stent, and when we look at this closely, we had to stent from the left main, and our plan was to put in a 4-row stent going into the ostium of the LAD from the left main, and that's our strategy. And through that, we would then advance a 3.528, just with a very minimal overlap covering the entire area. And our next job was to go ahead and put in that 2.518 there and optimally expand it. This was a run just after the laser, and you can see what we have there. You can see as we go from the distal part, you can see concentric calcium. But what is surprising is that even with the laser, we start seeing separation of these calcified rings. You can see a little bit of cracks around over here at 9 o'clock and a little separation down at 8 o'clock. And what happens is when our objective is to go and take an NC balloon, and we realize that the NC balloon does not expand, and we go through the length of the lesion to find unexpandable areas in that calcified segment. And wherever there's unexpanded segments, we use an IVL balloon. And here we ended up expanding it with a 4-row because our target stent deployment strategy in the proximal LAD was a 4-row stent. And so that is a 1:1 sizing of that IVL. And this is our IVL, our IVUS just post. Contrary to what's been published, our experience is that we don't see too much of a change in the pre-IVL and post-IVL luminal areas just by virtue of IVL. But of course, this does not prevent us from thinking that IVL has done enough to now ensure that the stent is going to be expanded symmetrically and completely, especially when you start seeing that with every progressive pulsation, when you start seeing complete expansion of that balloon, that signals to me that there has been some modification of that plaque. The problem is if we don't see that expansion, then we are in trouble. And I think that's important. It's then simple. We put in our stents and then go to our final balloon sizes. That is our angiographic result is right over there for you to see. And we realize that in the proximal segment in the left main, we've had a fairly large with a pot of 4.55. We've got 19 millimeter square area, followed by everything which is within the 90 segment. For 12.5 is a target for the ostium, where we got around 9.9, 9.2, and distally as we go along, you can see that's 9.3 and 9.3, which is a fair. There was a little bit of we would have loved it to be across to 10 in the ostium of the LAD. We went in with a 4 balloon to dilate it, but sometimes in eccentric calcium, whatever you do, you may not achieve complete, by definition, optimal expansion, which is a 90% expansion of your expected MSA. Once done, I think, so what is the take home for me? I mean, when I look at these kind of CTOs in the past, I mean, this is RCA, both RCA CTOs, you can see that you start the CTO and typically the wire crossing will happen within half an hour or 40 minutes. And then once the wire is crossed in a large number of these cases, you're struggling. Like this is, actually there's a typo, this is 46 minutes. And this is almost like an hour. We are struggling to get even the first balloon in. And you can see most of the times we're using guidezillas, multiple balloons, sometimes tornuses, sometimes other catheters. We're doing granuloplasties and things like that. And eventually we are able to get some balloon there to dilate, which is almost like an hour after the wire has crossed. And then, of course, it takes another 20, 30 minutes to complete a case. And our observation with excimer laser in this group of patients is are very small. It's just 2 cases with CTO, is that once you cross this wire, then the time taken to go to the next step is very low, which is almost less than 10 minutes, predictably. And then you can get your IVUS in, your balloons in, start dilating and go to the next step of completion of procedure. And I think the longer we remain in the cath lab, the more likely that we are going to run into trouble, is a dictum I follow in my cath lab. So shorter procedures are always better procedures. Taking you to a little bit of a complex scenario, this is a lady who presented to us with the severe angina, acute coronary syndrome, raised drops. As you can see the story, 66-year-old raised drops. She's had a previous CABG in 2010, so now exactly 11 years past. She's ILD on steroids, oxygen dependent, on ambulatory as well as at rest. And she's had a recent ACS with drops raised. She's preserved an ejection fraction, but the past ejection fractions have been around 60, 65%. There's a little bit of apical hypokinesia we saw. And this is her angio. You can see we'll take you through the angio a little more in detail. You can see that there's competitive flow into the LAD distally in this last picture. You can see a bifurcation lesion with a critical left main into the LAD and the circumflex, an early bifurcation which is involving the OM, and a long tubular lesion in the circumflex. What you see is a intervening graft segment, which is the radial artery graft, which is still patent between OM1 and OM2, but the other grafts are all not functional, except for this is your lima to the LAD, which is hardly giving any flow, any TIMI3 flow. It stops at the anastomosis, and your vein graft is actually showing a small PDA. So much is dependent on this circulation. To analyze, we have a distal left main. We have an ostial LAD, which is rather critical. There is calcium and thrombus in this lesion right here. And I'll show you some more. You can see that there's a little bit of what appears like a filling defect in that lesion. Ostial circumflex, proximal OM1, and a long tubular lesion in the OM2. And this is that bridge graft. In the original angios, we could see some filling, but when I took her for a PCI, you could see this critical left main, which was not visible in the other views selected, but there is almost no flow into the distal LAD. So we weren't sure if there was an actual lesion there or not. So this is our anatomy. And when you have calcium and thrombus and your CT, we do a CT map, and our CT shows that there's dense calcium, which goes along both the arteries, the circumflex as well as the LAD running through it. So we know that the bifurcation is going to give us trouble. And with a calcium score of around more than 5,000 and the kind of anatomy that we had, for us, this is almost like an uncrossable lesion once the wire is in. Initially, we attempt to put IVUS catheters in this to see if we can image, but we don't even attempt that anymore. Our first choice is to either do a rotational atherectomy and then follow up with a high pressure, one of the high pressure cutting balloons or IVLs, and then DS. Our second option was to consider a high pressure balloon directly, given the fact that there's some thrombus there, to avoid any slow flow or distal embolization, because the two big fears we had were slow flow, and the problem is difficulty in crossing these highly complex lesions. And when you try to cross these with devices, there's a profound ischemia because of the absence of flow, and then hemodynamic compromise with drop in blood pressures, and profound ischemia is one of our biggest challenges. We know that our past experiences, we've used rotational atherectomy, and those are associated with perforations, stuck burrs, installed burrs, dreaded slow flows. Though I do believe that, having shown these ghastly images, I still believe that rotational atherectomy is one of the safest devices to use in experienced hands. And we've been doing it for the last 22 years now without any issues. The price we pay for aggressive rotational atherectomy are these complications and possible mortality outcomes. So in this high risk slow flow situation with a left ventricular end-diastolic pressure of 20, a large area at risk with ILD, there's very little lung reserve. For me, this is an Impella mechanical circulatory support assisted case. So we had an Impella going in, and we used a 2.5 Impella. And this is for just about everybody to refer to, that even though LV function is good in complex CAD, it may still be for unprotected left main, where you expect a large region to get ischemic. It's a great tool to kind of think about. Once that was done, because of that calcium and thrombus, we took up a 0.9 excimer laser. For us, it's 80 fluency. We did the LED first. You can see the ease with which it kind of just follows into that segment. Once again, you can see there's no backup of the guiding catheter, so it gives you an idea of how easy that was. There was a little bit of a struggle when we go into the circumflex artery. It took in a while. I went to one point and then I had to withdraw and then go back in, but eventually a little bit of backup of the guiding catheter, but we're able to kind of get a very free flowing passage for this 0.9 millimeter fiber. This is the image which was before, and this was the image after. And what we saw was that there was complete filling of the LAD and there was no distal lesion. It was just a very competitive no flow going in there because of the high grade LAD stenosis from the acute coronary syndrome. Once we did that, what are our options now? We had actually ticked off the excimer laser. We've got some flow there. The LED is looking much better. The OM branch is kind of a little compromised, but we're okay. Now we have the choice of a high pressure balloon, a cutting balloon on IVL, and then the DS. So in our lab, what we do is we take an NC balloon and make some space. So it's safe in this large left circumflex artery. We've stopped using 2.5 balloons and 2 balloons. We go for a 3.5 balloon in this proximal segment because we want to cut the chase. It fails to expand clearly at 18 atmospheres. And once it does that, we've identified an unexpandable area in the proximal segment. And so let's look at the IVUS. And this is the IVUS. You can see that the IVUS pulled back from the LAD, the IVUS pulled back from the circumflex. What it tells us that this is the distal left main that you can see. The proximal part of the LAD has, though this looks like very scattered calcium, there's a calcium which is there. The lumen is narrow. It's almost gets to around 1 at the ostium of the LAD, and around just inside the ostium, it's a relatively rigid looking artery. The circumflex, though it's large, you can see plates of calcium on both sides, and these are difficult. And our NC balloon and our laser have already done a little bit of damage to that, but maybe not all, and there must be deeper calcium. So just don't be fooled by some partial fractures that you see. Eventually, seeing and citing a fracture on the calcium, as Dr. Luca pointed out, is not synonymous with a full expansion or vice versa. What is important is that if you are looking at a target artery, you need to be able to expand the target size balloon completely before you start committing that artery to a stent, or you're going to leave unexpanded areas once the stent is there. So for us, the reference vessel was the landing zone. The reference vessel was 4.8 in the LED, but the landing zone was around 3.5 again over here. And it went to 4.5 in the left main. The circumflex were a larger landing zone in the luminal area. We go by lumen diameters for our stent assessments. It's around 4.0. So it was obvious that we were going to take a 4.0 IVL, and we then went on with a 4.0 30 pulses in the LED, followed by another 20 pulses in the circumflex. We saw complete expansion, and then we gave the rest of the pulses into the LED, and you still see that part of the balloon is not completely expanded. So we bear that in mind, and for us now, what is our stent strategy? Our stent, we want to place one stent here. We want to go ahead and put in our second as a DK crush into this, going and putting our third into the left main to serve, and then a tap into the LED. That's our plan. However, nothing always goes to a plan. So when we did this using a Guidezilla, got a long stent in there, we got that, but you notice that we had proximally caused a small amount of dissection there, and there was little staining of contrasts, might have been a little subintimal placement. And then we patched it up with a small piece of stent there. We got the OM2 out of the way. We did an IVUS, and we had perfect expansion. Then we dilated. So on our CT, we realized that there was not much calcium in the OM1 branch. So that gives us a lot of relief, saying that we're just going to use a Wolverine. And for us, the Wolverine is a great balloon. And the reason I think it's a great balloon is because we get sizes of 6mm balloons, which is like very focal dilatations. You don't need to dilate unnecessary areas. So we achieve a complete expansion with the target. And this is post that Wolverine balloon. And then once we put in our stents, we've done a DK crush in the OM into the circ. You see the LED, and we've gone through the strengths of the struts, and that is a Wolverine 4.0, which goes to a higher pressure to make sure that post IVL, sometimes you still need a high pressure dilatation to just make sure everything expands well. This is the IVUS. I won't go to details through this. Our final results this is our final results. And you see that it's very important to look at the axis for this. And of course, we achieved our MSAs, which are corresponding to the sizes of the stents that we chose. Access care is most important in these patients. I just want to very quickly go through a patient, a 44-year-old gentleman. You can see that he had he presented last year to a hospital, to a private hospital elsewhere with the circumflex OM and a circumflex lesion. The LED looked mildly diseased, but nothing major in both the views. And what was done was the operator thought we dilated with a 2.5 and then 2.5 long and a 2.5 not so long stents were placed in this fashion here. You can see when you take a closer look, you can see that the OM was there's an OM stent going from the ostium of the circumflex into the OM, and then from the branch point into the circumflex. The first stent was the circumflex stent, which was then a classical crush was done, and the second stent was deployed. A kissing balloon was done. We did not see any port which was recorded in that angiogram, but this was the final result. And angiographically, it looked great. And the patient did well as well for a few months till he started having angina again and came back 10 months later with this anatomy. This is something we see, isolated circumflex lesions with not much disease in the left main LED, and it's a constant problem. And this is the problem that we had at hand. The LED, though looks diseased, doesn't seem still majorly involved. At best, it is around 50 to 60% ostial diameter narrowing, and we'll show you what we found. But we have a crushed stent in the circ, and we have a OM branch with a straight core stent right up to the ostium. Our first choice in this was to use a LCA balloon, and that is because the patient had mild heaviness of chest with coving STs. Sorry that I don't have those ST segment display right there, but we had that. So we did an LCA into both the branches. And once we did the LCA, we realized that we had better flow into both the branches. The patient was felt better. His STs were more isoelectric. And then we did a QCA, which showed around a 50% diametric narrowing. The ostium of the LED, you can see the MLA is 3.5. So when you look at the data for a 4mm artery with a 3.5 luminal area and the ostium of the LED, it still sits at the border of what might be. A few could still be FFR negative and a few could be FFR positive. So we didn't want to get into that space. Our job was to go ahead. We had to treat a high pressure balloon dilatation of these segments. So what we did was we looked at pullback from the circumflex and pullback from the OM. You can see that the circumflex is a fairly disease-free artery distally. The stent that was previously used is 2.3 in a largish artery, an undersized stent, not fully expanded. And you can see at the branch point, you can see that the stent is deformed. The MLA is significantly compromised because of the bifurcation strategy. And this is not something uncommon we see, and that's why optimization of this procedure is very important when we do bifurcation. The OM1 is diffusely diseased, and we didn't want to kind of get into that, but we found a comfortable landing zone, which was even very compromised. It was just 1.8mm stent expansion. But this was a 6-month result, and I didn't want to go into the disease area, so this was good for me. And the ostium of the circumflex looked seriously, of the OM looked seriously undersized and underexpanded. And you can see a huge amount of positive vascular remodeling that you're seeing around. Same here with the ostium of the circumflex. So for me, the left main was 4.3. The distal landing zone in the LED is 3.6. This was my pre-circumflex dilation LED picture. And this is my circumflex from the other side. You can see that the circumflex area, you can see that the LED, there's a lot of tissue in that area, space here. So when you start dilating this circumflex more and hard, you will see that the LED is going to compromise because of, if you can see, the distribution of plaque is almost concentric here, and a lot of it is on the carina. So this is how we planned to do a 4-0 Wolverine here, and we thought we'll place a drug-eluting balloon and sort this out. Optimally dilate this with a 3-0 Wolverine at 16, and then probably do a crush for these two arteries. This is exactly what we planned. We did that, and once we dilated the circumflex area as well, you can see that the QCA shows a reduction from 53 to now 75, 80% QCA reduction of area. So one should recognize that just an FFR negative LED through the course of the time when you're doing an ostial circumflexus can become significantly narrowed by virtue of displacing plaque or tissue or carina. And so what we did was we did a DK crush. We kept a 3-0 by 24 stent because this was 3-0 in size as a target. And we kept a 4-0 Wolverine balloon to crush the stent. Our second stop was expanded it completely. Our third was to take a 3.5 shot balloon and expand and do a pot in the OM. Thereby, we maintain the patency of the circumflex as well. And if you notice, our cutting balloon is just parked over there for the moment. And once we are done with that, we expand our cutting balloon and we do a crush and we do a dilatation of the left main at the same time. We do our first kiss, then we do our stent deployment, and then we do our pot, a second final kiss with the LED stent, and then a final pot. I think this is the final result we got. And you can see that we've chosen a very small artery in the OM1. So you can see that this is a small distal branch, but we had actually got it up to a pretty good 2.9 area, which was almost less than 2 initially. And the LED ostium and the left main is very, very optimally expanded. So having said this, 2020 onwards, our options have changed. You know, we had aggressive angioplasty. And when I mean aggressive angioplasty, I mean single burr escalating to a second burr, 1.75 or 2.0. And after that, we had these options of these high pressure balloons that were available in our cath lab. And we used them quite selectively in various anatomies. And when it would allow, we would directly put these devices in without using rotablator. If the lumen would allow the advancement of these devices, the whole idea was to optimally expand the stents. The limitations, as you can see, is the size burr is only 2.0, and these are all sustained high pressure devices until we had the excimer laser, which allowed us to expand our indications in the calcified areas with thrombus, and the IVL shockwave lithotripsy balloon, which actually expanded which actually gave us a little outreach on calcium. And because of that, it has actually shaded our OPN balloon and scoring balloon usage in our cath lab, which has come down drastically. And this is also a reason why we have to maintain a limited inventory. We can't keep everything on our shelves. Where and how these new fits will fit into our algorithm, time will tell. But for me, the first thing is CT. And once CT is done for a lesion, we need to get to imaging using IVL CT. But the first thing is the imaging catheter may not cross. So the question is, does a rotavire cross? If the rotavire can reach the distality of the artery, then it's rotablator for me. If not, then it's Tornus or ELCA. Maybe orbital atherectomy will help in the future. At this present time, I don't have it in my lab. And once I get to this point, I still have to go back to imaging. And for imaging, I divide this. I look at assessment of wire biases, because that tells me that I can escalate my burr. It's a cheaper option, a very effective option. Eccentricity is something very important in proximal arteries. Eccentricity with calcium means undersizing the stent, and fractured calcium used to be, it's now more academic. It doesn't matter to me whether I see it or not. Once we define concentric, we either go to high pressure, we almost always go to high pressure with flextome. I know at some point we went directly to shockwave, but I think now the pragmatic approach is to take the second path, which is more cost effective. In calcified nodules, if there's a wire bias favorable, is escalation of burr is the best strategy, I believe. If it is not, the wire bias is not favorable, we come to our old techniques and we wonder what is going to work. We really don't have a great solution for this. Deep non-protruding calcium is not a problem. I'm going to skip this one for the moment. I'm just going to go very rapidly through this slide. But my last slide for this presentation is, when we've got to this point, how do we proceed clinically? I mean, we can look at the images and say whatever we want to say, but for me, the practical approach is step one. Step one is look at wire bias. If there's wire bias is favorable, escalate the burr. It's a cheap option. It's a very effective option. Or use an NC balloon, which is IVUS guided and IVUS sized 1:1 to decide and decide those areas which are truly not expandable at high pressure. And for me, high pressure is 18 atmospheres. Once I know that, my second step, based on the calcium that I saw, I would either decide to use a Wolverine balloon, which is an eccentric calcium, or one-sided less than 180-degree calcium Wolverine. In the concentric calciums, IVL is very effective because that way I'm not wasting IVLs, which don't do a great job. And then I may come back and interchange and go to an IVL if I still can't expand, or go to a Wolverine, as I showed you, to get better expansion and stent delivery. Thank you very much for this listening.
Okay, as usual, Kirti sir, very extensive, and I think each case probably we have a lot of things to discuss, but unfortunately the allotted time is too low and we are already running behind. And what I suggest is we'll hear to Dr. YVC, and end of YVC's talk, we will discuss about whatever we discussed in the past two, including Dr. Luca's and Kirti's and YVC's presentation. We'll have a small discussion before we go ahead in between our further discussions. So I think it's over to YVC, sir. Just go ahead and do it.
Thank you, Selva, and good evening, everyone. Mine is a simple talk. Sometimes calcium blinds us to the severity of the lesion. It looks mild, but then it grossly makes us underestimate. Sometimes it's cinefluoroangiography really lets us make the biggest mistake of thinking calcific nodule, like a thrombotic lesion, and then once you go in, and then we'll end up in big trouble. So imaging wise, is it really important in such cases? We will show two things. On the other hand, sometimes calcium just comes out as a red herring. Everywhere calcium, radial, ulnar, the femorals, the pericardium, even the coronaries, LADs, but then stenosis is not much. So this is a really tricky thing, and we are going to see this more and more. And practices, at least 1/4 of or 1/3 of the cases are all full of calciums, OCABGs, and other scenarios as well. So we need to do imaging because this comes in several shapes and forms, spicules, pebbles, hillocks and mountains and canyons, and in clinical scenarios also are worse. And difficulties every step have been highlighted by Luca, and we'll end up sometimes in scenarios where you feel you take the devices and you feel like you are driving a limousine to a tortuous, narrow rivulet in the Rocky Mountains. The three traps, especially for the youngsters, should be aware of in dealing with calcific-lesion PCIs are the 3 Cs. The crossability, the device crossability could be a simple NC balloon or an OPN balloon or a IVL balloon. The crossability varies, of course. The crossability, the lesion crackability. You will crack the lesion with that, but this doesn't mean much. You need a good carpetability. The entire vessel should be good enough preparation for the bed so that the stent will expand well. So all the three are important, and many a time the crossability is not an issue. Crackability also might be some of a smaller issue as well, but this is the biggest trap, and the one should be very well aware before you deploy the stent and get a great result. And how imaging helps here? Of course, we have all our tricks. I will just concentrate a little bit on the crackability and the carpetability. The crackable, non-crackability could be really a non-crackability. Sometimes you do get the illusion of crackability. I've seen cases where people have attempted a 2 mm balloon and then NC, and it looks like it's cracked, and then they just go in and put in a stent and will end up in trouble. Sometimes it's a nodular calcium or eccentric calcium. The vessel will expand on the opposite side, and then it looks like the balloon has opened up well if you use a sub-sized balloon. And of course, there will be a radiographic illusion. It's important that you take a cine and make sure it's cracked. And of course, unsafe crackability is a concept we should all keep in mind. Just because you cannot go on inflating the device, put a OPN and then go to 40 or 50, because if it is an unsafe territory there with the normal vessel surrounding the calcific blocks, then you can end up in a big trouble. And here is where the calcifium specific crackability techniques like IVL come up into the picture. And now I think that is one of the best benefits to the interventional cardiologists from the innovational side. Of course, superficial and deep also make an impact. And this is again where calcium specific technology like IVL makes a big impact. I personally believe that imaging gives a tremendous information, the arc, the length and the thickness. All these are important for each of these issues, especially the crackability. The arc and the depth and the nodularity is very important to know that, and to choose a calcium specific technology like IVL. If you know that the deep calcium is there, then you can make the choice well before. And for carpetability as well, the depth and the nodularity is important. And this is where especially OCT is going to help us. The proof of the pudding, of course, is in the eating, and you need the devices and you go and then do. And the effect of the intervention also can be assessed by these imaging techniques. OCT is paramount importance, absolutely. But then there will be scenarios where you will not be able to do, and how do you tackle there? So I'll just show two cases for on the contra side. One, a post-CABG calcific terrain, of course, is notorious. You can see that. Just to minimize. Yeah, so you can see the septal there. There's a bend, and at that area, there's a critical calcific block there. Many a time we can start using a Guidezilla and then do the case. This is the IVL. It shows, once it comes over here, there are calcific nodules, thick fibrous cap as well, and then comes areas where entire 360 degrees of calcium will come up. There's a big calcium nodule there. The depth is more than 1 millimeter. So you can see densely narrowed up. You know that is extensive all around, deep as well as long. And of course, all the way here as well, it was severe. So this type of calcium lesions, if you know already, and if you have IVL and if finance is not an issue, this type of lesions ideally should, you can go ahead with an IVL instead of putting time on non-calcium specific technologies like high pressure balloons and creating some barotrauma. And still you will not be able to achieve a great carpetability for a good stent expansion. So if you see, surprisingly, some of these nodules will have a thin cap fibroathema as well, 30 microns there. And the trailing edge of calcium is not seen at all, so deep, so dense, all around, long, but easily guide wire bias, of course, is there. Sometimes, as Kirti was telling, it might suggest the benefit of float ablation here. Once the IVL balloon can go in, that would be the choice. And here IVL 312 was used each 6 cycles, can do everywhere. And this is what happens. You can see such a dense calcium, you can see cracks happening. Will not go more into the imaging, and you can see all the cracks over there in axial cuts, in the longitudinal cut as well. And as pointed out by Luca, it's not just the cuts which are there, sometimes multiple cuts in each axial section, long cuts, that's also an issue. And more importantly, the compliance of the calcific lesion itself is changed. So when you put a stent and then expand it to high pressures, it nicely expands. Except for some cases, of course, where still you might get some eccentricity if you're not done a good job or undersize the IVL balloon. So this was it, multiple cuts, deep cuts, long cuts, and put a stent, the usual things, stents, post-dilatations, the usual thing has to be done. And here again, the imaging role. Post-procedure imaging is very important, otherwise you might not get a great optimal result. So here is a great, good, easy result. But then again, imaging might not be available many of the times in some of the labs, and in some cases where imaging, especially with OCT, might be contraindicated for various reasons, especially the renal issues. So then what to do? Use a cinefluoroangio assessment. There might be red herrings. You can use the balloon boost once you cross. In fact, I personally believe that when you pass the wire itself, you know the nature of the calcific block you are dealing with. If the wire jumps at the calcific lesion with some difficulty, you know it's a mountainous terrain with a small rivulet hole, and the device deliveries are going to be tough. You can put the balloon there, the initial NC balloon, and do a balloon boost, what we call stent boost. You use it there, and you can see the amount of calcium very well. A balloon crackability test has to be done with a cine with the appropriate size balloon. Otherwise, you will end up with the illusion of crackability. And once you have a rotablator, IVL, and probably a covered stent, once these 3 therapies are there, I don't think calcium lesions are any more of a bigger concern. So this gentleman, post-bypass, Lima was supplying only the diagonal. The LAD component was gone. Dense calcific lesion here, of course, one more. Focal lesions distally, very dense calcific. Advise a redo surgery, but it's with a venous graft, it's not the right choice. A 6 of radial axis, XB3, the usual works. Run through growth with a classical jump in. A 2 mm NC balloon, ideally, as you said, it is not, it just tells you how the things are as a balloon is tracking well. This will allow you to take an IVL balloon if you want easily. Sometimes we want to avoid the IVL balloon, and you do want to do, you've not done the imaging, you're taking a bigger balloon, and you take a 3 mm balloon, you have to open it up fully well before you deliver a stent. It looked like the up. So a 3 mm balloon, and then you see it in a cine, you can see amount of calcium around it doesn't give way. So the previous were all the illusion. Many a time I have seen this happen in cases where calcific lesion, the stent deployed, and then it won't open, and they will be referred to you with recurrent ischemia post-procedures. This is what the problem was. So here, there's no point, a 3 mm going to highest pressures. You could use a open NC balloon with a higher chance of barotrauma, or knowing at all as there, even though you didn't have the IVL, the NC balloon crackability test was positive for the necessity of IVL use, and the classical IVL, and then that's appears good. Stent, the usual works, post-dilatation, distal lesion works, and then again, a good result. So calcification comes in many forms. It troubles us at many steps of PCI, and you need to just not be happy with just crossability of the device and the crackability with the NC balloon. You have to ensure that there is a good carpetability, and an imaging with OCT probably throws very many advantages. But once you are not going to have it or use it in that particular patient, you use the other points which I highlighted, especially the balloon crackability test is very, very vital, important. And also, I personally believe once shockwave IVL is there with you, the fear of calcium therapy, calcific-lesion PCI is no more an issue. If three things you have to use now in my lab for a calcific-lesion PCI to increase my confidence, first IVL, second rotablator, and third probably a covered stent. OCT, yes, if I have it, I will use it. I will probably put it as number 4 in that list, and I would like to have all my 4. Unfortunately, we do have all the 4 in our lab. Thank you.
Very nice presentation, YVC sir, and you made a good emphasis on role of imaging as well as doing it without imaging, especially IVL. And I think we will open it for discussion. We'll have a 10 minutes discussion before we forget whatever we discuss. I think Dr. Lucas is also here, and it is over to the panelists. And we'll see if Dr. Hazra, you want to start up with any points to Dr. Lucas and Kirti and YVC here?
Dr. Luca has nicely elaborated up to 3. We have now this CAD4 from Japan. We have UK, Italy registry data of all comers of IVL, like including left main, ACS. The beauty of having IVL is there is no slow flow, low flow in the acute coronary syndrome. Other things he has mentioned nicely. It is safe, no dissections, and it is unfocused energy, and the tectonic plate changes in many directions. And he has covered, and Kirti has covered each and every point. Over to you.
Yeah.
Dr. Manjunath here.
Yeah, yes, sir. Dr. Manjunath, yes.
Yeah. Anyway, those 3 lectures were really wonderful, and this explosion of debulking technology has revolutionized the PCI in all calcific lesion. Virtually contraindications have become indications. So that is the scenario we are seeing in last 10 years, not just in cardiovascular practice, in even otherwise also. So Dr. Kirti has presented really high complex lesions. So definitely a combination of these debulking devices in a single case gives a successful outcome. Sometimes it is, of course, more popular is rotatripsy, and lasertripsy also is another combination. So this works in combination. So strategy, I mean, planning is extremely important, as has been shown in all these 3 lectures. The only thing is probably laser angioplasty, excimer laser role comes particularly in a combination of thrombus and calcium, because other devices works only in presence of calcium. This is one area where both for hard lesion as well as soft thrombus, both it works. I think this laser causes what is called photolysis of the thrombus, because it basically acts by photothermal, photochemical, and photomechanical mechanisms. Even hardly we see a slow flow whenever there is a thrombus. Otherwise, in rotational atherectomy, we see in presence of thrombus, sometimes we see the slow flow that complicates the whole procedure. This is one area where laser angioplasty definitely has additional advantages, both calcium plus thrombus, both. Then another thing, in saphenous vein interventions, normally we don't, of course, rota is not advocated. So saphenous vein graft intervention, again, laser angioplasty has an additional advantage. Dr. Kirti, I just wanted to know, in a CTO, where wire is not crossing, yes, as you said, the laser comes I mean, as a first priority, if you are not able to cross the lesion, right? You're not able to wire the lesion.
No. So for me, the laser comes after I've crossed the lesion with a wire. but I'm not getting any balloons across. I can't get my microcatheter to track the wire. And I see that, we see that quite, it's quite frequent. It's not infrequent to have a wire crossing, but the microcatheter not tracking it. Now, in those circumstances, when you're sure that your wire is in the distal lumen, I think it's a great idea to take a laser catheter, because your laser catheter will loosen the bonds around, your microcatheter will go, and then that opens up your whole plethora of devices that could be balloons, or it could be a rotational atherectomy, or anything beyond that. Now, I know that laser has been used to modify the proximal cap even on a subintimal wire. That means my wire is in the subintimal space. I know it's gone subintimally, distally after crossing the C2, but nothing penetrates. So I take a laser and I just modify the proximal cap for those 2 millimeters, then remove the laser and take my macro catheter inside and then change wires to get back into track. I think some of that work my colleagues have talked to me about coming from UK, but we've not done that in our practice. Our experience is very short for that kind of experience to develop. We've only got laser starting in January this year on the 3rd week. So do you, right, Dr. Manjunath? And so maybe in the coming years we'll have a little more. But I think in an acute infarct, I think it would be terrific if it's a large thrombus burden and you don't know, because thromboaspiration doesn't work. You think you'll pull the artery back. There's thrombus at the ostium of the LAD, and you fear that you might push it into the circumflex. Take your laser catheter, burn a hole, get some flow down there, and then let the lytics or let the antiplatelets work, and just sit back. You establish TIMI3 flow, your patients are better, and then typically things improve over time. I think that is my hypothetical indication. I'm waiting for a case of that sort.
We have done a couple of cases for acute MI presenting day 4, day 5, where thrombus are a bit older. So this laser has really worked very well. They were, because late presentation, older thrombi has worked very well. Because of course I was going through this Carmel trial actually. There they have done this laser as a primary angioplasty procedure, and with a very high success rate. In fact, that has encouraged us to use laser, particularly young MI patients in India, particularly smokers, do have a large thrombi. Probably this could be one of the things we can always consider.
And it protects the distal bed as long as you don't push it too aggressively and wait for it to take its own path. I think the other amazing point you made is that when you start talking about thrombotic lesions, you can have a variety of catheters. You could use a 1.4, or you could use a 1.7 or a 2.0 catheter if you have a fairly large guiding catheter, because you don't need to go to fluencies of 80 repetitions and 80 fluency in these thrombotic lesions. 40-30 is good enough. Sometimes you need to go to 45 at the most, but low fluencies, because the only catheter which allows you to go to 80 is the 0.9 fiber. So if you're talking about CTOs, then you can't go with the lower fibers. But if you are thrombus, then you have a variety and you can take away a large part of the thrombus. I think that's a great indication.
I just wanted to know, suppose if, of course, basically laser works only in moderate degree of calcium. If it's heavily calcified, it doesn't work.
Yeah.
So suppose if I don't have an IVL in my lab, only laser is there. Do you advocate we can use some contrast for a better, bigger vapor bubble?
You can do that as long as you're certain that you don't have an eccentric plaque, which is very close to a normal artery. Because when you use contrast, the barrow trauma that you create because of contrast, microbubbling, macrobubbling is huge, and you can rupture the normal segment of the artery. So the question is, after doing once you go in, if you can get an imaging catheter inside, then you probably don't need a laser. But if you can't get your imaging catheter inside, and if your wire says that you're too close to the border of don't use it in a de novo artery, especially on a bend, because you could perforate, especially if the catheter is on the outer curve and the plaque is on the inner curve. then that is a dangerous scenario. If the plaque is on the outer curve and the catheter is tracking the inner curve, it may not be such a big problem.
Fine. So coming to the next question, like there are a few important points. If Dr. Lucas is there, coming to IVL, like we were always worried, like how common is this IVL balloon rupture, and what is the significance of this rupture, and how frequently have you come across with this IV ruptures? One. Another one is that ectopics or dysarrhythmias, like basically something like a VT-VF, which occurs post IVL, or are we planning any new modifications for this? There's two things to you, Dr. Lucas.
Well, these are actually very technical questions, and I'll try to be very brief. So, or at least in my experience, but I can talk about the country experience because we collected all the cases done since 2018. The rupture of the IVL balloon happened twice in almost 250 cases. And it was associated with the, well, I would say just some kind of transient slow flow because of the contrast that you use to prepare the balloon is exactly the same contrast that you use to prepare another balloon. So in terms of problems related to the balloon rupture, I would not say there's no issue at all. So well, there are other issues, I must say, particularly in European countries. I'm talking about financial restrictions, unfortunately, and that's for the first questions. And please say again the second question, please.
Ventricular ectopics or arrhythmias.
So this is something that we observe since the beginning. There are cases where, in particular, when you are very close to the conduction system, and I'm talking about, for example, the proximal LCX, the proximal or mid RCA, you can have some ventricular captures. And in my experience, it didn't happen, never happened that you have, let's say, malignant arrhythmias, but it has been reported. So it's hard to believe that this is something significant because in our experience, in all these cases, it never happened, but it has been reported, in particular in the Disrupt CAD3 trial. Of course, this is something that is under evaluation. And I can guarantee that the company is working to actually deliver new generation and new iteration of the catheter. Of course, because you know that this IVL balloon is available in a few measures. And of course, there is still a matter of trackability. One of the main limitations of this balloon is the fact that it doesn't really cross that good. In other words, nowadays, you can actually have an easy life when delivering a stent, maybe an under-expanded stent, than the delivering of an IVL. This is something that at the beginning of the experience created a few troubles because you can actually successfully deliver the stent. I mean, you can get to the lesion. You do not expand the stent. However, you can get there. With the IVL balloon, sometimes you cannot get there. And this is also most prevalent when you are dealing with distal lesions. So the technology is mature, but there are some iterations coming. And definitely they are oriented in improving the trackability of the balloon.
Dr. Lucas, I have a question.
Please.
I had a patient where I did the IVL for a very heavily calcified left main ostial lesion. And this patient went back home, and after a week came back with pericardial effusion. It went on increasing. And after 10 days, it went into component, we had to aspirate it. And we started all this drug. We thought it's a case of post-cardiac injury syndrome, and we started all the indomethacin and all the drugs. And after 2 weeks, it settled down, pericardial effusion disappeared. So have you come across any case, or have you, in your series of cases with IVL?
Well, I can tell that I had a similar experience when I was treating a patient with the in-stent restenosis of the ostial RCA well, that in-stent restenosis was the third time. So there were 2 stents inside the ostium. So I dilated aggressively, and then I used the IVL. So I created a dissection of the coronary cusp, but of course, well, I was lucky, and the patient was lucky, because we didn't have any pericardial effusion, but there was a dissection. So I've learned that in some cases, in particular, when you are very close to the ostium of the left main, or maybe the LAD or the RCA, you can create a damage in the pericardium. One thing we must remember, we still don't know what is the real interaction of the shock waves very far from the probe. So in other words, when you are very close to the pericardium, we don't know really what is this interaction. And in particular, in situations where you're using a large balloon, maybe the size 4.0, of course, the energy that you're applying is actually involving a large area. So I can tell this happened to me once, and then a colleague of mine, he had a similar experience as yours. It ended up well. Nevertheless, it had a pericardial effusion. See, this is probably a consequence of the energy, because maybe the energy applied sometimes is too much, but this is also under investigation.
This is the case with patient developed pericardial effusion after 7 days of index procedure, and it went on increasing and developed pericardial tamponade. We had to take it out. We have sent this case for American College of Cardiology case report, because I have never seen any case, any IVL case presenting with post-pericardial.
No, me neither. I mean, at least after such a long time, because of course, in acute complications, we have seen some, of course, but after a week, I must say that's really unusual.
Thank you very nice.
So I think we'll go to the next presentation now. We are already behind schedule. And then in between, probably we have only 3-4 more presenters. At the end, probably we can again have a small discussion like this. And it is over to Dr. Apoorva, who will be presenting on complex IVL case now. Dr. Apoorva, it's over to you.
Yeah. Can you see my slides?
Yeah, we can see it. Yeah.
So I'll cover a particular subset of what we have discussed previously. Is already implanted stent and your patient comes with ISR and there is calcification. So ISR due to underexpansion of stent is one of the mechanisms of DS ISR, which is still fairly common due to either poor judgment or poor preparation of the de novo lesion, leading to a suboptimal stent expansion, despite the best post-dilation effort. And as Dr. Reddy said, visually, sometimes it looks good, and still when you do imaging, it is pretty bad, or when you do an FFR, it is pretty bad. So this is the old algorithm of balloon undilatable lesion. We'll stick to the ISR part, where previously it used to be high pressure balloon, you use a shorter balloon, you simultaneously use 2 NC balloons, put a buddy wire, use angiosculpt or cutting balloon, chocolate balloon. But when nothing is going to work, you can use laser or atherectomy. But the new kids on the block were the very high pressure balloon and the IVL. So we'll try to discuss a few cases. This was a 47-year-old male diabetic, morbidly obese. I had done a primary PCI to LAD and a PCI to RCA in 2015. And he has LVH with good EF, underwent bariatric surgery later. This time he presented a few months back with 110 kg weight, new onset rest angina. ECG was normal, the drop was marginal. After 2 days, recurrent angina led to an angiogram. And as you can see, the LAD stent is quite good. The RCA is big, and there was a 4x40 stent. You can see the tramline calcium throughout. The stent was extending from the proximal to mid RCA. So this is jumping. So there are 2 lesions, both within the stent, not at the edges. First lesion at the mid RCA, second is at the acute margin. And you can see the lesions here clearly, and these are the stent boost views after the pre-dilatation and using a tool. This is the balloon boost what Dr. Reddy talked about. And you can see the first lesion, there is under expansion. The second lesion also there is under expansion. Looks like a sort of a nodule here, calcific nodule, which is pushing the stent. Now this is coming after 5 years. This is the IVS, which shows calcium throughout, and the MSA at the proximal lesion here is quite low. So there is a severe lesion. The distal lesion looked like a nodule. This is not caught in this IVS picture because there are two segments of the IVS. I have not got it on the plate. But the distal one was a nodule and the proximal one was almost 270-degree calcium, which was under expanded. So what we did is crossed it with pre-dilated with 2 mm balloon, went in with a 4 mm IVL, 30 pulses at the distal lesion, 50 at the proximal lesion. And then this was the picture after the IVL. We needed guideliner support, body wire support to get the another 4x40 stent in ultimately, but we could manage with the guideliner support. And these are the pictures coming up. And we got a fairly good result at both the lesions, visually at least. By the time, because of the wire manipulation, the PDA was having some calcific plaque which got lifted up, and patient really started having bad angina and ECG changes. Those were a pretty big PDA. And this was very difficult to cross. Filter XTA, Whisper, Pilot, all three failed. Ultimately, with a microcatheter support, cross it 100 succeeded, but the balloon was not going. So we had to take the guideline right into the PDA mouth, and ultimately the balloon crossed. We opened the lesion and put a 2.75 stent, post-dilated to 3, and got away with a fairly good result. So this was the final picture. The distal PDA lesion was good. Both the lesions opened well, and the IVS shows that the MSAs are pretty good at both the sides. 12.68 at the proximal lesion, and because of the nodule still with the IVL, it is not opened up fully. So the 8.5 millimeter square area at the distal lesion. So what I'm trying to say is that visually pleasing final stent picks are deceptive. As Dr. Reddy pointed out, DS ISRs do present fairly later than what we typically imagine. ISRs with DS come at 1 to 2 years, but this was 5 years. And I've got another patient which came at 10 years. So that's pretty unusual, but common. Good stent boost with orthogonal views can be used to assess the need for calcium modifying adjuncts, provided you don't have IVS or OCT available at all. IVL did help to manage this nodule calcium here to a certain extent, but not necessarily foolproof, as we have discussed already. Sometimes it doesn't work at all on the nodule. New guideliner saves a lot of adrenaline. Microcatheter support will be useful even in non-CTO occlusion sometimes when this kind of thing happens with a calcific lesion. Now, my question is, could this possibility would have been managed without the luxury of IVL, using simply OPN balloon? This we'll discuss with the next two cases I'm presenting as similar. This is a patient I had done in 2018, I think. And here the patient had undergone acute primary PCI to mid-LAD in San Francisco. 2 months down the line, he had a refractory angina, restenosis at focal site. Another stent was put in San Francisco. And another 2 months down the line, patient came to Surat. And he had again similar situation. And this was a 99% mid-LAD lesion. There were 2 stents at the site. As you can see, the balloon testing showed that the overlapping stent, there is one focal site where there is a plate of calcium, both sides. So it must be a circumferential calcium. IVS was also showing the same. The NC balloon did not dilate, and with the OPN balloon, we could get a full result at around 40 to 42 atmospheres. And still there is some residual, but we got a fairly good result. Patient has not come back since then. This is another patient, first time underwent a proximal to mid-LAD angioplasty for an acute coronary in 2002 by another cardiologist. Presented with an acute MI in 2008 to me, and again underwent a stenting. Both the times we thought that the results were good, but then patient came back in 2010, 10 years down the line. Both were DES. As you can see, again, the overlapping stent site is having under expansion grossly, although there is no significant calcium at particular site, at least on the stent boost. So must be a very fibrotic lesion. Again, the balloon testing showed that the balloon is not expanding, and we put a OPN balloon there, and OPN balloon kept on slipping back. So ultimately, I had to put another wire, block that OPN balloon with a proximal, another balloon, and then expanded it to 40-42 atmosphere and got the fairly good result, excellent result there. So my question is, what would be the new algorithm for under-expanded stent ISR? This has been discussed by Kirti already. Uncrossable lesion, which is not very common. Maybe you can get through a nano, otherwise you have to go for a rotor laser. depending on what you prefer or what you have there. If the lesion is crossable, do imaging or do a boost picture, predilate the lesion. Then if it's a fibrotic lesion, you can do a cutting balloon or an OPN balloon. If it is a calcific lesion, you can preferably, if you feel safe, do an OPN balloon and keep an IVL standby, or you can go for an IVL balloon. The last point is to be left open to the debate. Thanks a lot.
Very good presentation, Dr. Apoorva. And I think we'll have one comment from the panelists, like if Dr. Chadha or Kirti or whoever is there. I think Dr. Samir, who wants to make a comment for the treatment of ISR now. Dr. Samir, Dani, or Shrivastav, you can just make a comment. One comment and we'll go to the next presenter. And I call upon the next presenter to load his presentation, please, by the time we are discussing. Next is Dr. Sreekant Shetty. You can just come up with your presentation. Okay. If there are no questions like that, but probably how often is it like in an ISR with calcium? Do you think IVL will be more useful or what? Best point is always that, but you leave alone, that is probably, if it's not an ISR, it's a different story. In the case of ISR, if it is severely calcified, and what do you think is the role of IVL? Dr. Kirti or whoever is familiar with that can come up with their explanation.
Sorry, would you like me to take this? Yeah.
Yeah. Yes, Kirti, sir. Yeah.
Right. So I have my logic just tells me that in the ISR, I skipped over one slide in my talk, but that was the ISR component that I ran through very fast. There are two types of calcium that we see. One is the calcium within the stent, which is the new calcium in the new plaque and the new narrowing that has come up. Some of that calcium is as a result of a protrusion of a small calcium through the struts into the lumen from a previous PCI, like in Apoorva's case, to some extent. And the other is the long-standing calcium that happens. And the long-standing intra-stent calcium, I have almost not seen in ISRs which come within the 1 and 2 years. But after 3 years and 2.5 years and 3 years, the ones which come, almost 100% of them have intra-stent calcium in them. The peri-stent calcium is the other one. That is the stent, which is the calcium outside the stent, which is there. Now, the intra-stent calcium is so bound by the stent struts itself that I feel that it is going to be difficult for an IVL balloon to crack that lesion. Even when we use the IVL, when there is a stent, there's a conduction of that acoustic energy. I think what cracks is the peri-stent calcium outside rather than the intra-stent. I think for the intra-stent calcium, today I feel that the best technology still till date is still a rotablator. And I feel if you can do a 1.5 rotablator, but then almost always go to a 1.75 rotablator or a 2 rotablator, I think you can shave off a lot of the intra-stent calcium and that nodule. And then you have choices of a volver. But I think the OPN in this particular area is an amazing thing because it holds its size even at high pressure. And that's a technology that I would look at. IVL needs to be tested as to, when you use a 50 IVLs and if 10 of them don't work in this present time, that's a very expensive loss. Whereas if you use an OPN balloon, 50 and 10 don't work, it's still an acceptable loss in that sense. So I think if the cost of the technology were to come down, we wouldn't be talking about it. But being so highly expensive, we should limit its use to where we think it is going to get the desired result in close to 95% of people. If we start having failures in the range of 15 and 20%, then the cost of the balloon will kind of weigh down on the efficacy of that device as well, I think.
Okay, fine. So we'll go on to the next presenter, Dr. Kuntal. And it's over to you, Dr. Kuntal. Please take over. Yeah, make it full screen. Make it full screen. You are visible. Yeah. No, first click on. Oh, yeah, correct. Kuntal, you are muted. Please unmute. Unmute, please, Kuntal. You are muted. Yeah.
Yes, sir.
Yeah, now we can hear you.
Okay, thank you, sir. So, thank you for the excellent briefing and very educational lecture by Dr. Kirti, Dr. Luca, and Dr. Reddy. So, this is my first case. This 55-year male presented with chest pain with in a soft state. He had inferior wall MI with severe RV dysfunction on echo, and at presentation had metabolic acidosis of pH 7.1, very uncontrolled blood sugar. So primary PCI was a very high risk during this pandemic. So I was also not very much eager to go ahead with primary PCI with very high risk patients. And patient relations also declined, knowing the risk. The patient was thrombolized with TNK. The patient arrived at hospital within 2 hours. He had VT almost 6 hours post thrombolysis and ultimately intubated, and after 48 hours extubated. He had severe RV dysfunction, which improved after 5 days, then inotrop discontinued. And this is the angiographic view. It is a flowing artery, semi-free flow. But you can see this is a proximal RCA. There is a calcified lesion, and it's a quite tortuous also. So with all risks explained, and I'm thinking whether I should start with rota. Then I thought there must be some thrombus. So after starting, initially I pediatric with 2.12 balloon, and you can see there is a segment. So there is just creating a passage. So I did the OCT, and this is the OCT run. You can see there is a very tight lesion with the calcium depth of almost 0.8 millimeter. And at this point, the calcium is almost covering the entire segment, 360-degree arc. And the length of the calcium is almost more than 15 millimeters. So the choice is probably I want to avoid rota in this kind of cases because of getting a slow flow after rota. So I choose to do a higher size balloon, 3.12. But you can see there is a dog boning and the proximal part. Next, I have taken the IVL, but I have an experience of taking down the IVL with a difficulty in a bend. So I preferably use Guidezilla to avoid any injury to the IVL balloon. So the IVL balloon was cracked with Guidezilla, and the entire shock was delivered in the proximal segment. So all cycles shock were given. Then it is after the last shock, then balloon was inflated at 10 atm. Still there is some calcium is there, and probably it is not totally ill. When I took another OCT, you can see there is a beautiful cut, as Dr. Reddy has probably shown. So this is a beautiful cut along its all the axis and entire circumference. So I think the lesion is well prepared, and probably the debulking has been done adequately. So another 3.5 into 12 millimeter balloon was taken, and the lesion was prepared further with 14 atm. So the proximal lesion is still not very much opening up clearly. So I've taken now OPNNC, but all the gadgets are taken down with the help of Guidezilla. So whenever I use the OPN balloon, I usually prefer to use a body wire because there is a tendency of sticking the wire inside the balloon, so I can lose the wire access. But as I was using a guidezilla, so the second wire I could not pass. So this is the result. But ultimately, what happened? I could not take down the. I could not take back the wire and the balloon within the guidezilla because everything got stuck at this proximal part. So ultimately, I have to take the entire thing out. Then again rewired smoothly and taken the guidezilla telescope inside the proximal part of RCA. And the stent was 3.5 into 48 millimeter Zion expedition was taken. The stent expansion was smooth at 10 atm. But the problem started to taking down the NC balloon for post dilatation. So at this point, nothing going beyond this area. So probably some hugging calcium nodule which has got fractured and causing problem. So I changed the wire. After changing wire, then I thought it could be wire bias, so that is preventing my guidezilla to getting down. Even I cannot take down my OCT catheter to that area. So visibly that lesion was not so bad. So after several trials with the third change of wire, I failed to pass a small balloon of 4.4 into 6 millimeter. So ultimately, the lesion was post dilated adequately. And this is the post dilatation at the proximal segment with 4.5 NC balloon. And this is the final OCT run. So you can see this is a good stent expansion and a position, and the lumen gain was adequate without any significant tissue prolapse, or I cannot see any calcium nodule here, but I don't know why. Probably the stent anatomy has got deformed at that vein and causing problem. So this is the final result. Another case, a very short, I am telling just it is a 104 kg obese. Yes,
Until we are running behind.
Okay, sir. Okay, sir. Then it is okay.
Can you just, or else you can just tell the final emphasis about whatever you want to tell about this.
This is actually old. Yes, yes. No, it is an old lady actually post-renal transplant is again a very tight calcific lesion. And another exam is showing it's a very tight calcific, almost napkin-ring calcium. The results went smoothly well with IVL. Because it is a post-renal transplant patient, so OCT was not preferred in this lesion. And as a very obese patient, post-COVID recovered, the score was almost, lung score was almost 20 by 25. And after 1.5 months, she developed one NSCMI and attended in emergency with severe chest pain. The results are very good. So the presence of large calcific burden in coronary lesion adds an extra level of clinical and technical complexity to PCI. And intravascular imaging can provide details about the degree of calcification. And when it is not possible to do OCT, the IVS will give you the similar details. Only depth of the calcium cannot be assessed. And information derived from the intravascular imaging will allow the operator to select the most appropriate technology to prepare the lesion with high calcific burden. Thank you, sir.
Okay, fine. Very good. So actually, we predominantly, Kirti sir, it's for you also. Probably one question on Dr. Kuntal's presentation, but he clearly suggested, but imaging is also good, and he showed OCT and IVS. While doing selecting IVL on IVS, what criteria do you think that you should look into to say that you will definitely require an IVL? And how do you decide? Probably Kuntal or YVC or Kirti, any one of you can say that. But on OCT, of course, we have certain criteria which is very suggestive. What do you look in IVS to decide? It's for overall knowledge.
If I have to answer this very briefly, calcium in one set. So calcium on OCT or an IVUS, in my experience, may not be the only reason why a device needs to be selected. I think it gives you a geographical map of the calcium, but eventually my decision to use an IVL after an NC balloon is going to be when I find an unexpanded area with an NC balloon. I define that as an unexpandable segment. Then I look at the calcium distributed in that unexpandable segment and then decide if it is an eccentric calcium, then IVL is not my choice. And if there is a calcium nodule, Wolverine is my choice. But if there's more than 3 quadrants of calcium, then I clearly would think IVL is my first choice. So imaging followed by, I mean, you do a first rota, do your imaging, but whatever happens, whatever you find, first thing is an NC balloon to dilate everything. And with that NC balloon, 1:1 sizing, identify an unexpanded area. And in that unexpanded area, go look at your IVUS again from your previous run or your OCT. And there you decide that what is that unexpanded area, because that unexpanded area will determine the morphology of calcium there, will then tell you what is the most favorable device to use. But one decision that needs to be made very early before you do these dilatations is the escalation to rota. So escalation to rota should be done before you do high pressure dilatation.
Silva, I think people should understand what IVL balloon is.
Correct.
You have 2 markers. The distal marker and the distal emitter is 4 millimeter. The distance between 2 emitters is 6 millimeter. The distance between the distal marker and a distant balloon marker is 2 millimeter. And these 2 emitters are connected by one wire. So if you really want to have another emitter, the balloon size increases like S5 or something like that. You have a separate wire. That gives the maximum energy. So placing this balloon to have the maximum energy delivery and the maximum calcification thickness and the ISR stand under expansion is very important rather than just putting here and there. Over to you.
Fine. Okay. And I think we'll go to the next presenter, and again we'll have some discussion. It is to Dr. Shetty. You can load your presentation.
Good evening, everybody. Thank you for this opportunity to present in front of this esteemed panel. Are you able to see my slides?
Yeah, we can see it. Please.
All right. Thank you. So I'm presenting this case, a 73-year-old male, long-standing diabetes and hypertension. He was diagnosed with stable angina in 2014, found to have a calcific LED D1 stenosis with a distal LED being diffusely diseased and total occlusion right at the apex. It was taken for CABG at a premier institution, and then the surgeon closed the chest because he felt the LED was too densely calcified to do an endarterectomy. And the circ and RCA were mildly diseased then. So he had a futile thoracotomy basically. Now, after almost 6.5 years, he came with refractory angina, class 3, class 4, and unremitting biventricular failure. And that week he was admitted with us with the CCF, elevated troponin, bilateral pleural effusion. The echo showed severe biventricular dysfunction, pulmonary hypertension, and low EF. Creatinine on admission was 1.9, and recently his creatinine had been around 1.6, and he was hypotensive on arrival and started on inotropes, so diuretic infusion, and also treated as ACS. So he has now obviously a bad heart failure with cardiogenic shock and elevated troponin. And over the next 4 days, we tried to stabilize him. However, he kept on having recurrent rest angina, runs of polymorphic VT related to ischemia, and he remained on noradrenaline and dopamine and did not have symptomatic relief. And his creatinine climbed to 2.5. So he was obviously having refractory ischemia, decompensated heart failure, and a cardiorenal syndrome in the background of CKD. And he had previously been deemed unfit for CABG. And obviously, in the last 6.5 years, he would have had progression of coronary disease. So would he be fit for any revascularization at all right now? So should we cath and proceed? Would it be futile, exposing him to the risk of contrast nephropathy? Currently, he is inotrope dependent and in active failure. So any high risk intervention would be very complex, which meant it was a true chip situation. Or should we choose only compassionate care, stabilize medically and put AICD, which was not an option? And we explained the situation to the patient and the family, and the patient was keen that something had to be done to take him out of the vicious cycle. And therefore, after explaining the risk, we performed the CAG. This is what the angiogram showed. So obviously there was a significant progression of disease. The circumflex ostium had become a CTO. You can see the OM filling retrograde. LED remained more or less the same, but the diagonal had become a CTO. You can see the dense calcification all over, all the way to the apex. And you can also see the RCA, the PDF filling retrogradely. You can see again that the RCA also was a CTO with some hope there because there was a small microchannel seam. So a complex clinical anatomic subset, dense calcium, 2 CTOs, renal dysfunction, severe bioventricular dysfunction, and acute decompensated heart failure. Earlier rejected for CABG and again rejected for CABG. So we discussed again with the family and suggested that we could do an IABP supported IVL and rota assisted multivessel PCI, and hopefully with as less contrast as possible, which was a tough ask. So we put in a temporary pacer and IABP and started with the RCA because RCA was not supporting any of the other vessels. So we thought we wouldn't decompensate him so much by starting with the right coronary and then see how it progresses. The lesion could be crossed fairly easily with a Fielder XT with the help of a microcatheter. And then the microcatheter wouldn't cross the lesion. Then we ballooned with progressively larger balloons. Tried to cross with a IVS catheter, it didn't cross, but you can see from whatever image we could get, there is 360-degree calcium and with some nodularity there. Then further dilated with NC balloons. And then again tried to cross the IVS because we didn't want to do any injections, but the IVS catheter wouldn't cross. And then took the IVL balloon, 3 millimeter balloon, choose the 3 millimeter balloon so that we could use it in all the 3 vessels and pulse the length of the vessel. And then stented, all of this without any injections, and the second stent over there and post-dilated. And that's the result we got in the RCA. As you can see that the wire is in the PDA, which also seems to be a total occlusion, but we didn't want to do too many things there at the bifurcation. Just wanted to reduce the support on collateral circulation. So this entire RCA angioplasty was done with about 7.5 ml of contrast. Then we proceeded to the left side because RCA went rather smoothly. So I could cross the circumflex lesion with a little bit more difficulty than the right side, again with the fielder, but crossing the lesion with balloons was tough. We had to start with a 1 mm balloon and progressively larger balloons, then a Wolverine balloon, and then also pulsed it with the same IVL balloon, and then the first shot there, and then took a stent from the ostium, deployed it, and all of this delivered through a guideliner catheter and then post-dilated, and then proceeded to the LED. LED lesion could be crossed, but balloons wouldn't cross the lesion. So as much as I wanted to avoid rota in this patient who was very sick hemodynamically and in failure, I had to now use rotablation for the LED. So I did a rotablation of the LED with the 1.5 millimeter burr. And then took the IVL balloon also into the mid LED and opened it up. And then stented, long stent there, post-dilated aggressively. That's the result I got. And then I realized that there was something at the edge of, proximal edge of the LED, which also stented with one more short stent and post-dilated. That's the result in the LED. So IABP was removed the same evening. The whole procedure was done with about 60 to 70 ml of contrast. He diuresed well. Inotropes were weaned off over the next couple of days. His creatinine, which was around 2.4 at the time of the procedure, reduced to 2. And because he had a significant scar burden, I didn't want to send him out without protecting him against the risk of sudden cardiac death. Of course, it could be debated. So I implanted an ICD after 3 days and discharged 4 days post PCI, and he remained ambulant and heart failure free since then. And 15 days ago, unfortunately, he also got admitted with COVID-19 CT score 18 by 25 and discharged from that also. So, so that brings me to the end of the presentation. So, CRS improves with correction of heart failure and by improving perfusion. Use of hemodynamic support is very crucial for high-risk PCI. Watchful use of contrast is a must, and combining IVL and ROTA is a great strategy for severely calcific lesions. Thank you.
Very nice, complex case, Dr. Shetty. And we'll have the other two presentations also, and then finally have the discussion. And it is over to Dr. Sharma now. He'll be talking on rotatripsy. It is over to you, Dr. Sharma. Kindly load it up. Load your presentation.
Good evening, everyone.
You should stop sharing, Shetty.
Yeah.
You stop sharing? Yeah. Now I think Dr. Sharma will can just load. Yeah.
Yeah, is it visible now?
Yeah, visible. You can go ahead, please.
Yeah. Yeah, it has been an excellent meeting. A lot of good lectures and now interesting cases. And I'll share one of my case. Calcified lesions are very common in a routine cath practice, and more so with advancing age and post-CABG patients coming up with multiple comorbid conditions like diabetes, hypertension, dyslipidemia, and chronic kidney disease, as we've seen last case. And we have multiple modalities for plaque modification, depending upon the location, whether calcium is superficial or deep, and about the extent of calcification, like 180 degree to 70, 360, or the type of superficial sheet-like or nodular protrusion-like. We have many modalities available in 2021. So modalities available are NC balloon, which we have been using, and scoring or cutting balloon. Now we have Wolverine. Rotablation orbital atherectomy is not available in country up till now. Probably we'll be seeing in next by 2022. And IVL shockwave, which is in use since February 2020. And eczema laser is also a recent entrant. At times, we have to use a combination of 2 or more modalities to achieve the optimal bed fixation, and all of these modalities are complementary. My case is a 63-year-old male who has been hypertensive last 15 years, also known case of CKD, and had anemia and peripheral artery disease. There was extensive autobilateral disease, and he is a known case of CAD with a history of Apoorva in 1992 in Delhi, and ejection fraction was 35%. He presented to ER with a prolonged resting angina of 45 minutes duration, and in ECG it was left main equivalent. There was a elevation in the V1 and AVR, and there was almost 10 millimeters depression in one AVL and V2 to V6. It was a clearly history of critical left main disease. So this was the presentation, and but on a cath profile, hemoglobin was 6.8 gram%, and so he was transfused 2 units of packed cell. Creatinine was 4.8. So nephrologist consideration was taken and started on optimal hydration and NSL-16. EF was 35 to 40%. LD had a severely hypokinesia, and he was stabilized initially on anti infusion, low dose infection happening, antiplatelet statins. And gastroconsultation was done for anemia, and upper and lower GI scopy was done and stabilized with pantoprazole infusion. And after a little bit of stabilization over 48 hours, he was taken up for diagnostic angiography. And he was found to have heavily calcified critical left main and long segment. In fluoroscopy, you can see the calcium starting right from the left main, which is quite critical. And the diagnostic was having a pressure damping. And this calcium was in a cranial view. You can clearly see it's a very tight proximal to mid-left Reddy disease. And there was a calcium moderate disease in the ramus also, and also in the AV groove in the circumflex. And RCA was diffuse disease, chronic occlusion, swelling from the left side corridors. So on the basis of this diagnostic angiogram and the overall clinical profile, CKD bilateral extensive aortic disease. We had a hard time discussion and surgeon refused for the CABG. So what next? There were multiple challenges because of advanced CKD. He was not on dialysis up till now, so can't use too much of contrast. And he was anemic and undergone upper low GI and treatment for that. So he's also a high bleeding risk in the underlying CKD and GI ulceration. And it had extensive peripheral artery disease, bilateral lag. No femoral access was available for, so can only go for the upper extremity for both LV support if required, and also for the PCI. So these were the challenges: CKD, extensive peripheral artery disease, no access from down. And he had a critical left main with a 3-vessel disease and critical ischemia. 10 mm tested depression globally with a 1 and AVRS elevation. CABG was ruled out, so only option was high-risk PCI with the Rath IVL with without LV support. And also IVS because can't use a contrast for the optimal visualization. So, so I took a left axillary axis for LV support if at all required, and the right radial axis with the glide sheet 6 French, which can accommodate 7 French guide. And also, if there is a challenge in the passing with the IVL balloon, then just cut just to break up the your left main ostium, left main mid body shaft, so that further on we can track the root ablation and shock wave, and eventually after preparation of DES and correcting and optimizing the IVS. So this is the first one. The approach is from the right radial, the XB 3.5, and the first wire went into the diagonal. So with that, we had a difficulty in tracking with the IVS catheter. So this is the endoscope scoring balloon just to break the lesion in the left main for the other devices to pass very easily. And then this run through wire in the LAD down, and which was extended over the microcatheter with a rota floppy wire. 1.4. And after that, this 1.5 the gentle packing movement. There was a resistance in the proximal to mid segment. There were multiple passes. We had been able to cross through this LAD lesion, and then subsequently the IVL balloon. These are 3.5 to 12 millimeter balloon, and started with delivering pulses in the mid LAD segment. You can still see there is a waist in the balloon, and we used multiple cycles of 10 pulses each in the proximal to mid LAD and subsequently into the left main. So all the 8 cycles were used, 80 pulses, and still there was a waist. So again, a NC balloon at high pressures and the scoring balloon also at 26 to 28 atmosphere in a whole proximal to mid LAD and also in the left main. And after optimal dilatation in the fragment right from the mid to proximality and left main, 2 overlapping stents. First one is a 3x30 in a mid to distal LAD. You can see it's fairly well expanded. And another one is a 4x30 overlapping with the previous stent and covering the left main ostia. And it was deployed at 16 atmosphere. And subsequently, still we can see a waist in the mid LAD segment, also in the overlapping segment and the proximal LAD and left main. So it was further dilated. In the left main segment, it was a 4.5 millimeter balloon, 18 to 24 atmosphere. And in the LAD segment with a 3 initially, then with 3.5 millimeter into 12 balloon, right from the mid LAD stent to the proximal LAD at high pressures, 18 to 24 atmosphere. And subsequently, we had IVS, and top one is a LAD from distal to mid LAD, and now the bottom you can see very well expanded stent in the proximal LAD, although there is a asymmetric expansion, and the ostium was very well covered. And we can see the reference areas and a very good luminal dilatation. And this is the final view. And in the cranial view and also in the caudal view, you can see the very well expanded stent. And also the circumflex and the ramus is flowing well. This was also with a limited amount of contrast, and the patient had a nearly stable creatinine post-procedure. So the calcified lesions are very common and pose a technical challenge. And the plaque modification for optimal bed preparation is of paramount importance prior to placement of stent. And imaging helps in assessing location as well as seeing the extent of the calcification. And frequently needs a combination of modalities. It's not the one modality, it's a combination of modality, and all these are complementary in achieving the good result. And it has to be rota, IVL, and now eczema laser, scoring cutting balloon, and then balloon, and a combination of the multiple modalities are used for achieving the best results. So careful clinical analysis or judgment accompanied with the operator's interventional skills and the team approach plays an important role in overall successful outcome. Thank you.
Yeah. Thank you very much, Dr. Sharma. And we'll go to the last presenter, Dr. Smit Shetty.
Sure.
It's over to you, Smit.
Before
Stop sharing?
Yeah, I'll try and share my screen.
Yeah.
Go ahead.
Go ahead, Sumit.
Yeah, can you see my screen and can you hear me as well?
Yeah, we can see your screen. Make it full screen.
Yeah, I'm going to do that. So thank you so much for the opportunity to the organizers. My case is actually pretty much similar to the cases that we have seen, tough calcified lesions where we are actually, faced with a problem as to how to go about it. Use a balloon first or rota first, combination of both of them or neither. So this gentleman that I'm going to be presenting is an 81-year-old male. He's a diabetic for long. He became COVID positive on 7th April and with a CT score of 14/25 was managed with the COVID physicians with oxygen, steroids and plasma, gradually stabilized and then was shifted to the non-COVID ward under them. On 7th May, he had unstable angina with resting chest pain. The troponin was positive. His EF dropped from a normal of 55 to about 35 with the regional wall abnormalities in the LAD territory. He also had some AKI with the creatinine going up to about 1.8, which resolved after 3 to 4 days of treatment, and which was managed medically. He was never oliguric or did not require any hemodialysis or any other dialysis support. So seeing this scenario with the resting chest pain, ECG changes, drop in ejection fraction, and the patient was fairly stable, it was decided to take him up for an angio after informing the family with the due risks which may be involved in the procedure. At the time of taking up for the angio, his eGFR was about 40 mL per minute. So this is the angiogram, which you can see there is a highly calcified distal left main lesion, proximal LAD lesion. There's some calcium in the proximal circumflex, which is not a very large vessel, but there's a large OM, which is also calcified and has some moderate to severe disease. There is, besides, of course, the distal left main calcium, there is some calcific disease in the proximal LAD segment as well. And the circumflex ostium appeared pretty hazy and dirty. And there's a large diagonal which we can see proximally, which is also, calcified and severely diseased. So this was the left side anatomy. The right side also showed that there was proximal calcified critical lesion with the distal vessel being fairly okay. So with this kind of a scenario, of course, a heart team discussion was taken, but because of his post-COVID recovery, being sick and elderly, the family declined for the procedure. Patient was not inclined for a CABG, and even the surgeons were not very keen. So the idea was to actually fix up the left main lesion, the distal bifurcation, and then probably plan for the RCA at a later stage. So we took him up with the femoral root next day, and this is a 7F CLS Boston guide. The idea was to actually wire all the three vessels, that's LAD, the proximal diagonal, and the circumflex, which we did initially. And of course, the plan, I unfortunately do not have IVUS at my center yet. It has got delayed because of the pandemic. We had OCT, but we were not very keen to use OCT upfront because of his AKI, and we had thought that if we get the chance, we might do a saline OCT to actually just assess the calcium and probably the vessel size. So we inserted 3 wires and tried to take, OCT catheter. It obviously did not, it crossed the left main lesion, but did not cross the LAD lesion. And, in this effort, the wires from the diagonal and the circumflex actually came out, but the circumflex was wired pretty easily by me. So I thought that, if required, we could probably go into the circumflex as and when required. So a BMW wire was taken down the LAD, and the lesion, which was the distal lesion, the mid LAD lesion, was pre-dilated with a 1.5 millimeter balloon. As we can see that the The balloon actually did not open up very well, but this was enough to actually, go beyond the lesion and crack it up a little. The other thought process that we had, that we did not want to use a rota up front because of the fact that he had LV dysfunction. The LED distally was very diffuse, and we were, a little skeptical about using rota and, having a slow flow and then putting him into more jeopardy at this time. The thought process was also to use upfront, whether to use upfront hemodynamic support, which was basically IVP in our case. But we thought that he was doing fairly well, at the time of the procedure. The pressures were fine. He was not having any saturation issues. So we had just taken an access on the left femoral side with a 5F sheath and kept the rota standby in case we did require that. So after having dilated with the 1 millimeter balloon, I could not pass a 2 millimeter balloon on a single wire. So I had to use a buddy wire at this stage. And this is a 2 millimeter balloon, and we can see clearly that there is a waist at about 16 atmospheres. So obviously at 2 millimeter, with a 2 millimeter balloon, the lesion could not crack. The next option was to take a slightly higher balloon. We took a 2.5 balloon, but also that also showed a kind of a waist. So since this was a crossable but a non-dilatable lesion, the next option, of course, was just to take a rota wire over a microcatheter. And you can see the microcatheter. We took a rota wire down this and selected a 1.5 millimeter burr. Now this was, we've done quite a bit of rotas in our lab, but this was a very, very sort of a time-consuming rota. It took almost 20 to 25 minutes. Obviously, multiple runs with enough gaps in between to let the vessel bleed, and for the slow flow to be as minimal as possible. So after a lot of attempts at this, finally we could cross in one of the scenarios, as you can see here, that it just crossed with a persistent attempt, and that was actually enough. We did not plan to do any polishing because I think it was just a calcific nodule which was troubling us at that point. And once we had crossed with the burr, I was sure that we would be able to dilate it with a balloon. This was the view post the rota. We can see that there is some distal embolization, but unfortunately at this time he was not having any chest pain or the hemodynamic instability. Thereafter, the 2.5 balloon could easily open up. You could see that the balloon is nicely dilated. And however, having suspected that this was obviously going to be a lesion with a lot of superficial as well as deep calcium, we chose to do an IVL balloon therapy at this stage. And this was a 3 millimeter by 12 millimeter IVL balloon, which was chosen to give pulses down the mid LED and into the left main as well. We could complete about 60 pulses at the proximal LED lesion, but at the first, IVL balloon dilatation in the left main, this was the only expansion we could achieve, and the balloon ruptured. So obviously there was cost constraints. We could not use another balloon, and this was a suboptimal dilatation of the left main. So we thought of taking a cutting balloon, and a Wolverine 3 into 10 millimeter balloon was taken, with which we went up to 12 to 14 atmospheres to get some sort of expansion of the left main with the Wolverine cutting balloon. Thereafter, once having adequately, in my opinion, prepared the bed, we took a drug-eluting stent. This is a 3 by 15 millimeter stent, which opened up pretty nicely, as you can see here. The balloon was pulled back and dilated further. The stent was dilated further. And we chose a 3.5 into 22 millimeter drug-eluting stent, which was overlapped with the first stent. And again, we can see that it's a fairly good expansion in the left main. Having done that, the rest of the stent in the mid segment was post-dilated with a 3.5 NC balloon, and a pot was done with a 4 millimeter balloon into the left main. These were the final results. Showed a fairly good expansion. The distal flow was a little low, but by this time, of course, it was a longish procedure. Patient was a little breathless, saturation about 93, 94. We managed him with a little bit of diuretic therapy, some oxygen, and with this kind of a scenario, we thought we'd just check the PA pressures. PA pressures were not very high, and he was shifted out. He did pretty well for the next 2-3 hours, but then started having more breathlessness, and the saturation fell a little bit. He also had a drop in blood pressure. The anesthetist thought it would be best to electively intubate him at this stage. He was electively intubated, but having some, having had this kind of a scenario, I thought it's best that we actually do a check angio to see if the vessels were flowing, especially the circumflex, though it was pretty good in the initial shots. So he was taken up for a check angio. He was already intubated by this time. The vessels were flowing. He was on a bit of inotropes at this time, and we then thought that it's advisable to put in an IVP as well, which was duly put in. Patient was shifted back. He did pretty well in the next 2-3 days. The situation stabilized. The IVP was taken out. He was extubated and made a rather good recovery. So I think my take home is basically almost the same as the other presenters, that in severe calcium, imaging is definitely very, very essential if you can just get the imaging catheter down the vessel. Upfront rota sometimes is very, very helpful, and it can prevent use of extra hardware like we did in our case, decrease the time, radiation, contrast, etc. If cost is not an issue, rotatripsy will likely, and in almost all the cases, prepare the lesion, but much better by taking care of both superficial and deep calcium. And I think all high-risk PCI, the chip cases, we should consider upfront MCS, especially IBP, if we do not have INPOILA because of cost constraints. Thank you so much for your patient listening.
Yeah, thank you, Smit. It was a nice presentation. And at the end, we have a little bit of time for only 2 questions. And any 2 important comments, like say anybody from the panelists wants to make?
We have nicely covered each and every point. This rota is basically a platelet aggravator. And GP2B3 receptor kind of thing. Laser is paralyzing the platelets, and IVL is absolutely neutral on platelets. You have to remember the difference between these 2 procedures. Second, if you have an ostial lesion or even a short left vein and ostial circumflex, if you use a device like orbital, which cuts forward and backward, and as well as rota in RC ostial, if you have a debris, like if you are drilling in the wood, the wood dust will go to the brain. So there are reports of having this kind of retrograde brain strokes with orbital and rota with RC. So you have to remember the IVL works better, definitely this. Only good thing about this tram track calcification CKD, you can have a zero contrast PCI just by seeing this tram track calcification. So in both these cases, you have seen that it is perhaps beneficial. There is only good side of having calcium. In Sumit's case, whatever you do in complex cases, the guide support is very important. Your guide was actually jumping here and there. And perhaps it was a snake bite kind of rota. I mean, you were just touching and coming and kissing the calcium. It's actually not doing any job. So guide support is very important. Over to you, sir.
Yeah, fine.
So if I can just respond to that. The lesion was actually so tough, and I was just not touching or just pecking. There was consistent pressure. We had to raise our speeds from 160 to 180, 190. But I think it was probably the wire bias which was not allowing us to actually, catch that nodule. And we were in fact lucky. We were planning to actually, change the burr to maybe downside to a 1.25 to see if it go through. But we were just lucky that at the fag end we could get the burr down the vessel. But it was a very, very calcified lesion, and the guide was backing off because of the fact that the calcium was so dense that it was not allowing even the burr to just, get beyond the lesion.
So it was really a good presentation by all, and only thing is time is the limitation now, and we still have a lot of things to discuss and learn about calcium. Because of lack of time, probably I think everything has to come to an end. One last comment, Kirti sir, you can make, and I think we'll close this session now. Dr. Kirti? You are muted, sir. You are muted.
Selva, thank you so much for moderating so beautifully. And I thank all these people for presenting some amazing cases. I've learned a lot. I think calcium continues to remain a big weapon. One, wants us to fail, and 2, wants us to create and make mistakes. So I think having an entire toolkit is very important. And when you take calcium into the left main space, I think all of us need to be very wary of we are now in 2021 and we cannot use an excuse that we don't have one or the other technology, because a left main is so eloquent an artery and it can decide survival and mortality even at the end of the procedure. So we should equip ourselves completely, understand the landscape even before we go into the cath lab, and then have a plan A, a plan B, and a plan C, and a ready action, like a drawing board to the cath lab situation. But I think the cases presented today was awesome. They were of tremendous complexity, and all the operators did a terrific job at completing them. And it was an awesome meeting for me as well, just like all of you.
So thank you very much, and see you all probably in some other sessions in some other meeting. Thank you, Hazra sir, and thank you
so
all
much.
the panelists.
Bye then.
And thank you all presenters. Thank you.
Thank you.